Case of a 54-year young lady who presented with lump in left breast for the past 2 months, for which she underwent evaluation outside, and she had undergone a mammography which was suggestive of Birad's 4A, for which they had advised a core needle biopsy, which was also done outside. But the report that we received here was suggestive of a lump in the right breast that had been biopsied, and it was suggestive of benign inflammatory lesion. But as per patient, she underwent, the biopsy was done from the left breast. They again outside only they underwent a review of the same slide, the biopsy slide. One of the review centers, they reported it as invasive carcinoma, but again of the right side, and another review center they reported is that as inconclusive report, again of the right side. When patient came to us 2 weeks back, we examined and there was a lump in the left breast which was approx 2 into 2 centimeter in the 10 o'clock position. And again patient was planned here at our setup for a USG guided biopsy from the left breast. It was done, and that again the report was conclusive of in benign lesion. Query either phyllodes and query post-inflammatory changes. So we all the aspects were explained to the patient with respect to the age and the Birad's grading, and patient's family as well as the patient took the decision of excisional biopsy for that.
Now, what would you have done? You see the cases reporting initially, probably we traced it and we found out that there is some technical problem, that left became right and right became left. So
in our setup, we redid the triple assessment of the patient. We again took the history. We did the physical examination of bilateral breast, where we found out the lump was on the left side, as the patient previously confirmed.
So the good point she's mentioned is we redid the triple assessment. So it's not about just the mammography, it's not just about the biopsy. So reassess, use all the three components of triple assessment, and that suggested there is a lesion on the
lesion on the
left side, and we did a image guided core biopsy, which is what is the recommendation today. So the image guided core biopsy was suggestive of again a benign lesion, right? But like us, there are a couple of confounding factors. So we took a decision the attendants were keen on removal of the lump, which is in the form of excisional biopsy. Now you can take it forward.
So patient underwent a wide local excision.
So we planned not excisional biopsy, we planned a wide local excision only, because that is not what is required. No, we need to, whenever you're doing a resection, you should do it with a clear margin. So what was a wide local, how would you define wide local excision?
So here first we marked, preoperatively we marked the lesion. So the lesion was at 10 o'clock position, but there were few hard nodules, as well as we correlated with the mammography film, and few calcifications were noted even at 12 o'clock position. So from 9 o'clock to 12 o'clock position, the area was marked, the quadrant was marked, and through that we...
Yeah, but initially we plan wide local excision. So what do you mean by wide local excision? Definition.
Wide local excision means excision of the breast tissue along with the tumor and adequate approx 1 centimeter margin in all 3 dimensions.
So 3-dimensional 1 centimeter clearance, correct? And we took, you're right, we almost took the entire quadrant. We went by raising the skin flap in, then approach.
Round block approach was...
So we use the round block or the Benelli approach, or also called as the donut. So that gives us a bigger window and access to go beyond the lump, right? Yes. And we raised the flap in the mastectomy plane, went beyond the tumor and took a wide chunk with clear margins. And what did we observe on the lateral side while the disease was all on the medial side?
So the main lump that we could palpate initially also was on the medial aspect at 10 o'clock, but while excising the lump, we could find a calcified, another firm to hard nodule on the lateral aspect. So we took another margin extending that lesion also, and on frozen section also, that only came out to be the main tissue.
So we basically got one, which was the original one, where the core was done also, because the pathologist could make out based on the hemorrhage and the inflammation. So we took a margin of that, plus we took an extra lateral margin because by feel of it, some elements of calcification, and also the mammography showed it. So we took that as a marker. Would image guided, I mean, would the wire guided have helped in any way?
So no, not that much, but it would have localized the lesion that we had already done.
So it would have, we had already taken care of that because the lesion was already, there's some bit of hematoma. It was palpable now, so that was not important for us. What we went by was the mammography, and we took a wider margin, making sure that we get a three-dimensional clearance. And what did we observe? Where is she going? What did we observe?
So that on frozen section.
Then we sent the three-dimensional, this was 7 into 8 centimeters lump of the lesion, which was,
grossly.
and then we sent it for, after orienting it, we sent it for frozen, and it showed 2 DCIS, one out on the outer side of,
There were 2 DCIS sites, one on the peripheral aspect of the main lesion that we could palpate, and another was on the lateral aspect that we also suspected, we also had that entrop suspicious about that lesion. So both the lesions were checked on frozen section and both showed high grade DCIS. But all were cleared, all the margins with respect to both the lesions were cleared.
What would be a clear margin for DCIS?
So 2 millimeters
Two
from the
mil-
ink.
From the ink, no? 2 millimeters. And for the invasive breast cancer?
Tumor on the end.
There is no 1 centimeter in microscopy anyway, so no tumor on the ink, and 2 millimeters is for the DCIS. So that's the margin, and 1 centimeter that they are referring to is a gross margin, not microscopic anywhere. So we got a clear margin all around, and then why did we do a sentinel node biopsy?
So it was only DCIS, no invasive carcinoma was commented on in the frozen section, and it is not indicated in DCIS to go.
So when is it indicated in DCIS?
When it is if clinically palpable nodes or if it's present in the
Did you listen to the question carefully? When is the sentinel node biopsy indicated in a patient with DCIS? It's a very direct question.
So if the mastectomy might be planned later on.
If later on,
If mastectomy is planned, we need to go for a sentinel node.
the indication is mastectomy. If you're doing mastectomy, you won't have breast in future for doing the sentinel node biopsy. So the only indication is one, if you are doing mastectomy for DCIS, it is required. Two, if there is a suspicion of an invasive element along with the in situ element. And in general, not recommended. The only indication is mastectomy if you are doing mastectomy for DCIS. When do you do mastectomy for DCIS? If it is a multicentric or there is extensive calcification, microcalcification, then you may, you may have to do skin sparing mastectomy with the. हाँ अब आप बताएं, ठीक है, उठ के बैठिए ना, आप तो लेटे हुए हैं, बिल्कुल लेटना तो है ही नहीं. आपके डिस्कशन की थोड़ी सी रिकॉर्डिंग हो रही है, कोई प्रॉब्लम तो नहीं है? नहीं है ना, इधर को देखेंगे हम. कैन यू? शी इज डूइंग फाइन, टेकिंग ओरली, एवरीथिंग इज एडिक्वेटली डन. We have done an adequate marking to make sure, and the notch to nipple distance is more or less the same. The symmetry is completely maintained, and we've been able to do it, and no drains. Tomorrow we can change the dressing and she can go home. This is round block mastopexy. I'm not removing the dressing. And you can see that everything is maintained. The volume is also breast volume. We did it by volume displacement by mobilizing the pillars adequately. And why no drain? Because drain is not going to help anyway. Drain causes drainage. If I had done axillary dissection, I would have put in a drain. अब आप सब कुछ खा सकती हैं. तो क्या खाना है आपको? पिज्ज़ा, समोसा, क्या पकौड़ा? हाँ, तो नॉर्मल खाना खाएंगे अब आप. और दूसरा वो आपको फ्रेजोविन, वो जो आपको एक पाउडर स्टार्ट कर रहे हैं जिससे थोड़ी शरीर में ताकत आएगी. अपना खाना खाएंगी, घूमेंगी फिरेंगी, कोई प्रॉब्लम ही नहीं है. जब आप जाना चाहें जा सकती हैं. आज भी आपकी छुट्टी हो सकती है. हाँ, तो अब कल जाना चाहेंगी तो कल भेज देंगे. अच्छा, वो जो एक चीज़ होती है चूसने वाली गोली, वो आप ले रही हैं कि नहीं ले रही हैं? दिन में 3-4 बार ले रही हैं वो, क्योंकि ये जो ट्यूब डलती है ना, जब बेहोशी होती है तो उसकी वजह से थ्रोट में थोड़ा सा कंजेशन हो जाता है. तो स्टीम इनहेलेशन एंड ऑक्सीलाइन गागल्स टू बी गिवन सिस्टर. हैज शी रिसीव्ड? गुड. एंड ये ठीक हो जाएगी, कोई चिंता की ज़रूरत नहीं. अब आप बिल्कुल ठीक हैं, अब आप घर जा पाएंगे नॉर्मल. ठीक है. टेक केयर. थैंक यू.